You're tall, Fernando. Thanks all, and thanks, John, for the introduction. So I told my mother, who is a homemaker and an artist, that I was going to be speaking here today. And she said, "Oh, what's the title of your talk?" And I gave her that. And she said, "I don't understand what any of that means." So I'm going to try my best to make this very engaging for everyone. So let's start by just defining what real-world data and real-world evidence is, because we hear this all the time. So the FDA, this website here, which I encourage you to read, but it gives lots of great definitions for everything that we're going to be talking about today. But what I really mean by real-world data are the natural history studies, registries, wearables, claims databases, electronic health records, and even social media data that are part of our observational research ecosystem. And so in contrast to the data collected under more experimental conditions like clinical trials. So that's the key thing to remember. And oftentimes these projects fall under the umbrella of big data. You'll hear that sometimes, real world data, real world evidence, and big data. And so the evidence or the insights that we glean from those data. And I should also be clear, I don't do mice, I don't do microscopes, I only do this kind of data. But that's why we have all the people who spoke this morning. And you will also see that our STARDUST model fully integrates with those teams. And just because it's in the title of my talk, this is the STARDUST real-world data, real-world evidence ecosystem. And so what we've laid out here is a real-world evidence in a box. Everything you need to hit the ground running with a big data project. But I'll explain all of this as we go. I'm glad I didn't show my mother that slide first. So I just want to give you a little background on how I came to get into all this work with real-world evidence. So this is my son, Charlie, a few years ago. Charlie's 14 now. And when Charlie was a baby, he had a severe form of epilepsy called infantile spasms, and it caused permanent brain damage. So he had multiple brain surgeries, and he still has a lot of seizures, and I have to help take care of him for almost all of his daily activities. My husband and I care for him. In the early days of Charlie's illness, I was actually a staff data analyst, not on faculty yet, but on staff at Johns Hopkins. And for many years, I worked on these very early, exciting real-world evidence projects, but they weren't very personal to me, right? And these were really new and exciting, especially because when Charlie was diagnosed and there weren't a lot of clinical trials for him, I realized all the potential of these big data sources and just what Fernando just showed, right? Just how exciting that could be to generate hypotheses and develop drugs. But it's only been in the last decade or so that this has become kind of a household term, this real-world evidence and real-world data. Back then is really new. And I was becoming a really sought-after data analyst just because I happen to have both an engineering background, data engineering, but also I took epidemiology for my master's. And so I knew about the scientific method. And a lot of the folks who work on these big data projects aren't really trained in the science as much as they are in the data piece. And so I became kind of a popular person at Johns Hopkins. So in high school biology, we all learn about the scientific method, right? Remember getting out your lab notebook, right? Remember that? And it's a systematic approach to understanding these phenomena. So you form a hypothesis, you design the study, you carry out the experiments, right? You collect your data, you replicate the experiment in other data sources, right? And you collect and analyze the data, you draw conclusions and share results. And these are the things that the folks in our lab do, right? And you saw this morning. This is the tried and true method for generating evidence. But in those early days of real-world data, I saw the scientific method go right out the window. When you have thousands of participants and millions of data points, it's like finding a needle in the haystack. Where do you even begin? How do you know that the data on the electronic health record are high quality? So these things were all up in the air. And because I was pretty good at doing some of this stuff, and it's pretty tedious and meticulous and boring, and I like that kind of work, I would hear this a lot. We wish we had more Danielles. We would like to clone Danielle. I heard that a lot. And that's really flattering, but also very disturbing, right? Because you shouldn't have to rely on having a unicorn data analyst to do a good job with your big data project. You should be able to do something like the scientific method, right? We should be able to just pick this up. We should be able to easily train people to do this work. So anyone should be able to do this. And, you know, I saw people who did things really, really well. Of course, I was working at Johns Hopkins. I saw some amazing work in this. But what I also saw was a lot of patient advocacy groups, especially in the epilepsy space, who were so desperate to collect evidence, to create registries in their child's rare disease. And then they would get all the data and they didn't know what to do with it, or they would collect it wrong. It was awful to watch. And they would call me, and I spent a lot of time, and I still do, I spent a lot of time volunteering for these groups. And so they had no idea what to do next. And then yet another group might be well-funded, like an academic medical center, and they would have all the staff and all the resources. And then if you were a nonprofit, you wouldn't. And so it just didn't sit right with me. And I didn't know about this until I had Charlie and all this happened, right? So it also seemed like nobody was talking to one another about what they were doing. So we'd get a new big data project and we'd start all over again, how we're going to approach it, what we're going to do. And it would just feel like, to me, like we were wasting a lot of time. So to be fair, real world data are different. You can't approach it exactly the same way that, you know, with the data types that we saw this morning. So what makes it different? Well, it's non-experimental. First of all, it's collected under, let's say, typical clinical conditions, for example, or you know, surveys that people from home might fill out, right? And there's diverse multimodal data sources. So in a clinical trial, it might be a little bit more standardized, a single data system. We have a very diverse population, so everybody can be in an electronic health record, right? And not these carefully selected groups, these controlled circumstances of these experiments that we learn about in the scientific method. We also have a lot of unstructured data. So think doctor's notes and how unstructured and unpredictable those are. That's not the same as entering things into a little spreadsheet, right? And having it all organized like you would in a clinical trial. A lot of times our data are incomplete or inaccurate. Sometimes you don't fill out a survey because you don't feel like it and it's optional, right? Or it doesn't apply to you, or you didn't get to it that day, right? So we have a lot of incomplete or inaccurate data. They're not randomized typically. There's what we call temporal variability. So these are long-term data with evolving patterns. So you'll have data from 2016, data from 2024. Clinical care may have changed over that time. And it's continuously evolving. So with a clinical trial, it kind of just stops. You analyze it, that's it. You set the study period and that's it. Whereas with real world evidence, it's constantly growing. And finally, these proprietary database formats create a challenge. So with like electronic health record, name brand electronic health records, they don't want to share their schema publicly, their database organization and how all their tables are named, which makes it really hard to communicate with each other about how to get the data out and share with one another. So back to Charlie. Like so many of you, we're caregivers and people with ALS. Despite working my full-time job as an analyst, I spent a lot of time in the hospital and by Charlie's bed and caring for him at home. And I would binge watch these police detective shows. And one day I'm at Charlie's bedside and I'm watching one of these shows in the hospital. We're at Children's Hospital, Philadelphia at the time. And I noticed that every time there was a serial killer case, there was always this flurry, this avalanche of clues. It could be this person, it could be that person. Who is it? False leads, right? Distractions. Look over there. This guy might have done, oh no, that wasn't it, right? But all of these shows, they approached the investigation the same way, right? They would scour the crime scene. They would make an evidence grid. They would do the canvas. They would interview witnesses and fingerprint, photograph. They wouldn't want to contaminate the crime scene. They would bag and document all the evidence just a certain way. And then they'd send the samples out so that you could look at the DNA and compare it against others. So I'm sitting there with Charlie. Here he is. And I glanced over at that keyboard station where the nurse was putting in the information about his, care that he was getting and looking up his lab results. And I thought, my goodness, that electronic health record database is a crime scene. And this epilepsy that's tormenting my baby is a serial killer. Or killers, copycat killers, just like with ALS, right? Many risk factors might be implicated. Maybe it's more than one killer, but that's what it is. So why aren't we all approaching these real-world data sets with such a rigorous, systematic, and harmonized fashion like the police on these shows? Or even the scientists in our labs who are using the scientific method with the same sense of urgency that you might place on catching a criminal. So I'd like to change the title of my talk. Can you imagine you're watching NYPD Blue and Lieutenant Fancy comes out to the squad and says, oh, the serial killer struck again, we need to investigate. But instead of running to the door, out the door to reflexively do whatever it is that you were taught to do in the police academy, they called a meeting about what to do for the most basic form of investigation, right? Maybe they set up a Google Doc outlining some approaches. Maybe they posted a job to see maybe this person could have the skills that we want, right? That wouldn't happen, right? Certainly there are new and innovative tools that we need to develop, but for some of this basic stuff, this should be reflex. So why are we doing it that way? And I was doing it that way. I was getting the orders to do it that way, right? And so this realization made me really mad as Charlie's mom. And it didn't occur to me until I actually had a kid and I was doing this work that this is not right. And I wondered, would Charlie have been spared if not for inefficiency? So this led me to get involved with all kinds of people and initiatives. And I came to know Fernando and the team at ALS TDI. And I realized it's also their desire to be rigorous and systematic. Even though we don't have it all figured out, we know what we don't want to do, right? And we want the same things, and we're just trying to figure this out. And we're trying to pioneer this work with other groups that we work with. So I knew I had found my people, and I started my full-time job 2 days ago. Thank you. And thank you. And we applied for a CDC grant to do just that, right? To create a systematic approach to the ARC data set and openly document, very key, openly document how we did it so that others across other diseases like Charlie's, like epilepsy, like cancer could learn from us. So now back to the Stardust, which I named because I like pretty names and I like the purple color. So after more than a decade of working on this and these types of projects, along with collaborators, especially some at the Critical Path Institute, you heard come up a couple times, I created this framework, and this is a comprehensive approach to everything you need to do to get started, to get going. It doesn't solve all your problems. It's just, this is what you need. This is the ecosystem. Kind of like, as I said, real world evidence in a box, and how we should train our teams and ensure data quality and communicate and continuously improve. So note, fair data principles are at the top, and these are the principles that are important to stakeholders like the NIH and FDA. So these are findable, accessible, interoperable, and reusable. And a lot of times on NIH grants, you're asked to report on your fair data principles. So we want to make sure we're doing that, right? And on the left, we have the steps to data curation, which is just gathering evidence, or integrate multiple data types, which is what Alan described so eloquently, all the different types of data that we have. We have to curate that. So on the right, we have data analysis. So this is the process of analyzing our data, our known suspects and our new leads, if you will, to make discoveries. And in the middle, we have our tools that spell out Stardust. And because my mother thinks this will be boring, I will only say that these are things related to the training, skills, data security, the quality, and other considerations necessary for any successful real-world data project. And I'm just going to highlight a few here. So understanding of Git is really important. So Git is a version control language, and GitHub is a platform. Go online, github.com. It's a platform for using Git and storing our code. So have you ever watched one of these shows and they have a cold case and they go back and they want to look at the file and it's in some dusty old evidence room and then somebody didn't do it right and they lost the evidence and then what? Right? That guy's in trouble, right? And maybe they have some DNA and it could exonerate them, but if not for the fact that they lost the thing in the control room, right? GitHub it keeps us from doing that with ALS research. Okay, that's all you need to know there. If we need to go back and look at our code, we can, and we can look at the versions and who changed it and why. And we can also share it with someone and they can take it and build on it and do something even cooler than we did and analyze it. But we can see that too in GitHub. So we don't want the killer going free because we didn't use the right tools, right? And then the other thing is technology awareness. So an example of this is what we're doing. So we just developed this really simple open source software tool that reads in those electronic health records. They come out looking like this. So this is how they kind of start. And that's not real data. And you can see it's Donald Duck. But that's how it looks when it comes in. And so we want to use it, want to be able to use it and analyze it. And so we just drop that in this free tool that's on GitHub. And this is how it comes out. You see, like that's so much easier to use. And that's free and open source and it's available on GitHub. And so I also want to share about standardized vocabulary. So you may have heard of billing codes like ICD codes. You might see that on your bill or your doctor might give you a specific code so you'll get maybe a medication covered. So we use those in electronic health records. And so there's lots of different kinds of vocabularies. And so this is key to our reproducibility, being able to standardize. And even if there isn't a billing code, you can also standardize to a common data element. And so I got involved with something called the Observational Medical Outcome Partnership, or it's also known as OMOP, which is a way of harmonizing all of our data into the same table names and the same field names using the same standardized vocabularies. And that way I can write code or make software that works on your database and the data never have to leave your site, which means nobody has to complain about patient safety or patient privacy because the data never have to leave, just the results. So OMOP is the way. And so ALS TDI is leading the OMOP effort in ALS with Answer ALS and CPATH. And in fact, and here's a slide about that, Brandon from, say hi to Brandon. Where's Brandon? Brandon he is here from Answer ALS. And we work together every week and we're standardizing the Answer ALS data with the ARC data and putting it in the same place using OMOP so that we can analyze it together. And so these are all things that are moving us in the right direction of order, organization, reproducibility, and collaboration. And I'm very proud of that because of everything we heard in our panel earlier. And so I also wanted to say that we embrace these other data capture platforms. Remember the scientific method. It's so important that we can replicate our experiments and other data sets. So personally, it's not separate data collection efforts that should worry us, but the lack of transparency and standardization in our methods. The lack of documentation and dissemination of our results. We do not need to be concerned about redundancy in the context of this open science Stardust approach. Oops. So importantly, note that second T, translation and communication. And I feel like this is where in real world evidence, we really fall short. Working with other jurisdictions, the police working with the FBI and the local police working together. That never goes right in those shows if they're not working together, right? And so ALS TDI is different. It truly is. After 30 years of doing this, most of that in academia, it's different because I'm able to communicate what I find to them. They're sitting right there. I can send them a text. I can send them an email, and there's a lab who can go back and look at the blood. So if I find something or one of the analysts finds something, we can immediately translate that and communicate that with the larger community, with the other researchers. And at the foundation of all of this is engagement with people with lived experience, which obviously is really important to me. And this is a two-way street. This is the Crime Stoppers. Isn't it always a valuable witness tip or a statement that cracks the case? Just like the police rely on these community watchdogs, we rely on our community to provide valuable leads and tips and to contribute precious data to the ARC study. So in return for all of your time and effort, all of this valuable participation in the ARC study, I commit to you as a mother and a data scientist that we are doing absolutely everything we can to get the evidence out of that database, out of the crime scene and into the lab, and not waste resources on approaches that are redundant or unnecessarily duplicative. To quote the Morris principles, share your data, designs, failures, and best practices. Your duplication of work is deadly. This is what we seek to do with the STARDUST-ALS approach. And we still have so much work to do. But with the right attitude and the right people and the right framework, we're creating a world where we'll be able to squeeze every ounce of insight out of these real-world data. And everyone from epilepsy to oncology to ALS can access these tools and resources. So thank you for your attention. And for you to remember that from now on, whenever you hear the term real-world evidence, you may know more about it than you realized. Thank you. Do I have time for questions? Thank you. Questions?
We have a question in the chat,
Sure.
which is actually from Fernando.
Oh, hey, Fernando.
Oh, wait a minute. That's for Tim. Sorry.
That's right.
Question in the
No
chat.
questions? I
Okay.
left you all speechless. All right. Oh, there was one over here.
So I'm just curious if, like, how far away are we from a, let's say, a clinical trial, it being a requirement that their participants get into the ARC program, as an example, so that, or does that make any sense? But
No, it does.
you know, if they're going to analyze all their clinical endpoints, whatever they are in the trial, that's obviously good data and whatever, but couldn't it be better data? And couldn't we gather more results from a trial if participants were in ARC and then could look at all that information as well?
Yeah, so that touches on several things. I don't know how much time I have to go into that, but that's an excellent question because we are pulling in electronic health record data. And there are a lot of studies where you can do analytics, you can do kind of pragmatic clinical trial. You can do clinical trials with data that are already in the EHR as long as you're capturing them well. Like Dr. Benatar has that toolkit where you can enter data into EHR. So something like that. So if everyone, let's just use that as an example. If everyone was using that toolkit, which they could implement these modules locally, then it would be a lot easier for me to find their data and for their sites to find the data, these high quality data elements. It would be easier for me to know if they were missing. The site would know if these data elements were missing. So I would say the answer to that is we're not that far off. There are a lot of projects underway with this type of study design. I would say the way from a clinical trial standpoint is likely at the sites, not at like self-reported data into like the surveys, but at the sites to be able to capture that, or some combination of a person sending data to a site and then the site sending it back to us. Just the point is having that infrastructure in place is where a lot of the missing data challenges come. But I think we're pretty close to that. And there's a lot of interest in the FDA and that website, for example, the things that we can do. That's a great question.
Hi, Danielle. So for those who don't know me, I'm Tanner. I'm part of Unite. We help with the electronic health record effort for ARC. One question I had around the common data model as it pertains to the electronic health records is how you get information from the unstructured parts of the data into a common data model framework where the data is really structured and tabular, so that you can analyze it readily. How do you document the process, that some AI tool may have gone through to extract that piece of information from the unstructured notes?
Yeah, so that is a great question. And one of the things that came as a surprise to us is, the ALS FRSR came up a lot in these talks today, and that is often in an unstructured form. And so you have to find it. And it's such an important piece. You would think you would be able to just pull up the one little place in the spreadsheet. There's the ALS FRSR, and it's not always there. There are a lot of groups doing this actively in OMOP. They have a natural language processing group. So OMOP is an open science community with lots of work groups, and we all work together with a use case. So this is one of the use cases that we're going to bring to them. Like a lot of the good stuff, a lot of genetic results, a lot of the good stuff comes in unstructured. And so that is concerning, because while you might get something like a medication or a pulmonary function testing result in a very discrete way, a lot of the other stuff comes in like a note, basically. But they do have a module for notes, and they do have there are tools to do, like you said, AI and NLP, to natural language processing, artificial intelligence, to extract the data. And I've done that. We've done projects like that. And then we just tell the code to drop those into the fields. But it takes a lot of validation to know that, to be sure that you're doing it right. I wonder if you're doing any work in that. We should talk if you're doing any work on that.
Thank you very much for your excellent presentation. As a clinician, I've done a lot of clinical trials in the past. I find that there's a lot of apathy out there. How do we get patients and data into the system? That's one of the problems I see in all these ventures.
Yeah, apathy, from the perspective of enrollment, it is challenging to enroll when you have everything else going on in your life. Like, as a mother, if you tell me this is not required, then I'm probably not going to do it. It's very hard for me because I have so many other things competing for my time as a caregiver. So I'm sorry. The question was, sorry, I didn't ask. The question was, as someone who works in clinical trials and as a physician, how do you overcome the issue of apathy, particularly in enrollment and recruitment? Because we have this great tool, why isn't everybody in it? And so that's part of it. Awareness is part of it. Reaching out to people who might not be in the places where we're recruiting is part of it. But as a mom, I can tell you what lit a fire under me was seeing other groups in the epilepsy space doing this really well and getting results and developing drugs and getting a clinical trial, and their kids are doing better. And so I think keep pushing this and showing some success. I think that is the best marketing, right, to get people interested. And also advertising the open source, the convenience of the ARC study, for example. You can do your phlebotomy at home. You don't have to leave your house to get the phlebotomy done, for example. That's a huge deal to me. So I think the ARC study is doing this quite well, and others could probably learn from it, for sure. But recruiting is always difficult, and recruiting diverse populations is always a challenge as well. Excellent question. Okay, thank you.